Good day, everybody. Today is February 6th, 2024, and I'm honored to have with me the esteemed Dr. Stanley Goldfarb, who has helped form a group, Do No Harm. Stanley, or Dr. Goldfarb, tell us about you, yourself, your mission. What is Do No Harm? What does that mean in the context of medicine?
Sure. It's good to be with you. Do No Harm started back in April of 2022, and it really came from experiences that I had when I was the associate dean at Penn's Medical School, the associate dean for curriculum. And I became aware then, it's something I probably should have been more aware of because I had done that job for several years, was that American medical education was descending into a sort of a morass of focusing on social justice issues and sort of leaving behind its main focus, which was supposed to be training physicians to be clinical scientists and to provide the best medical care that the American people could get. And more, we were supposed to start to train our medical students in social issues like poor housing and food deserts and gun violence and even climate change. This became an issue. And it just seemed to me that this was sort of absurd. I wrote about it in the Wall Street Journal. And that led to a huge outcry, comparing it to the modern day where people are saying all kinds of terrible things, particularly after the October 7th massacre in medical schools. And yet no one seems to be sanctioned very much for these, statements that they've made. And yet I was vilified. And so after that, I wrote a book that I entitled Take 2 Aspirins and Call Me by My Pronouns. This book was the same title as that Wall Street Journal op-ed. And it sort of went into all the details about where I thought American medicine was going and where American medical education was going and the concerns I had about it and the suggestions I had for sort of going back to the future and returning to a more traditional approach to medical education and improving the kinds of people that were the training that was being presented to people who were spending lots of money to become physicians. And I think we're getting rather poor training in medical school these days and in residency programs. And then the question was, what can I do about all this? It's one thing to just inform the public. It's another thing to really make change. And we decided to start an organization, as you mentioned, Do No Harm. Our website is donoharmmedicine.org. And we've actually been quite successful, sort of beyond my wildest expectations, to tell you the truth about this, because I think we struck a nerve for how physicians and other concerned individuals are starting to worry about American medicine, medical education. And we have two missions at Do No Harm. One mission is to fight back against discriminatory practices in medicine. And what I mean by that is the insertion of identity politics into medicine. And that includes this whole issue about medical education, as well as in the delivery of healthcare. And what I mean by discriminatory practices is the idea we have to treat people differently because of their race, of their skin color, or their ethnic backgrounds, or what have you, as opposed to treating them as individuals. And this involves both treating those who want to go into the medical profession, those who are in the medical profession, as well as the patients. And, some examples of the discriminatory practices that we ran into were, for example, Medicare back in 2021 issued a ruling that physicians who had some sort of anti-racist protocol in their practices would be paid extra by Medicare to care for those patients through the quality improvement program. And, well, of course, if you put anti-racism means racism. It means you're going to treat people differently because of their skin color. Now, Ibram Kendi, one of the gurus of racial politics, says past discrimination requires present discrimination to remedy it, and present discrimination requires future discrimination to remedy it. So we're never going to go away from these discriminatory practices, and he advocates, for these sort of anti-racist protocols, which he calls anti-racist, but in fact they're racist because you have to treat people differently based on their skin color. And this led during the pandemic to people reserving scarce monoclonal antibodies for people based on skin color. There were algorithms in California and New York which said that African Americans were going to get these treatments prior to white people getting these treatments, even though they were equally ill, because, or maybe even less ill, because they had been disproportionately affected by the pandemic. Not the individual, but rather the group, which really is sort of goes against the Hippocratic Oath. We're supposed to treat everybody as an individual. So we've been working very hard to get rid of all discriminatory practices, including going along with the abolition of affirmative action that was undertaken by the Supreme Court back in the summer. So we've pushed back against medical schools that have had plans to recruit students simply on the basis of skin color. And we know this has been going on for many years, where not the most highly qualified individuals were being accepted in the place to make sure that there was more diversity in the med school class. I think diversity can be fine. It may be beneficial under certain circumstances. Mark Cuban has been an entrepreneur that's pushed hard, says sometimes in businesses, the customers want a more diverse workforce in the businesses they deal with. That's fine. But in medicine, in pilot training, in neurosurgery, in other kinds of fields, in engineering, which is critical to the safety of the public and to the safety of individuals, I think you're obliged to have the most qualified individuals and not to compromise on their qualifications in order to create a more diverse workforce. And I know that's controversial, but I think most people, when they go under anesthesia and are about to face an important surgical procedure, are not really interested in social issues and not interested in social justice and not interested in diversity. They just want the best person. And if that person is Black, fine. If that person is Asian, fine. It doesn't matter as long as it's the best person available. And that's what families expect, and that's what patients expect. So we push very hard. We've had a number of lawsuits that we've put out there against institutions that have had so-called discriminatory activities. We sued a large drug company, Pfizer, who had a fellowship that excluded whites and Asians. We sued a medical journal, Health Affairs, that has had a fellowship program that would train students about medical publishing and the ins and outs of medical journals, but whites and Asians were not invited to apply for these programs. These activities are all illegal. If an organization takes funds from the federal government, they're obliged to follow the civil rights laws, which were promulgated back in the 1960s, which say that you cannot discriminate based on race or gender or any other immutable characteristics. The other thing we've done is that we've sponsored legislation. And this legislation has been carried out in a number of states, particularly Midwestern states, arguing against the so-called DEI regimens that have been put in place in medical schools. These regimens involve bureaucracies that force sort of the kind of speech that is consistent with the diversity, equity, and inclusion mentality, which means that, again, you have to treat people based on their group characteristics. You have to get promoted. If you want to get promoted in medical schools, you have to show that you're committed to diversity initiatives. If you want to do research, you have to show that your laboratory has a diverse cohort of individuals in the laboratory and that you've promoted it, which is particularly absurd because, of course, research should be about people who are the most qualified, the most capable individuals performing very difficult intellectual activities of discovering new medications, new treatments, and so on. The fact that they're African American or Asian or white or what have you should be totally irrelevant to that activity. So that's been what Do No Harm is about. We're up to having 7,000 members now, over 7,000 members who have joined us, physicians, nurses, and we continue to get information from our members, and we then act on that information, and we've helped craft legislation, as I mentioned, and we've conducted lawsuits, and we've had lots of op-eds, many hundreds of appearances on television and op-eds in important journals like the Wall Street Journal and like the New York Post and other publications, pointing out the fact that in our country, we should treat people as individuals and not as members of a group. The second mission, which we took on, which I think is quite related to the first one, but I think is equally important, is this whole question of gender-affirming care for children. And the reason we took this on is because every time we spoke to people about what we were interested in, the inevitable comeback was, what about this gender-affirming care question? How do you see that all fitting in? And we saw it related in a few ways. First is, these children that expressed gender dysphoria, this confusion about their gender, when they're quite young, were being treated as a group. They were being treated as trans kids. And you might have seen that even yesterday, there was another whistleblower who had worked in one of these gender clinics in this time in the state of Washington, came out and said the children would show up, and despite whatever psychological problems they had, they would immediately be classified as a trans kid, quote unquote, if they said, that they were confused about their gender. Or some of them weren't even confused about their gender, but were recommended to go through this social transitioning and then being put on puberty blockers and then taking hormones that change their secondary sexual characteristics. All in the name of this idea that children who express gender dysphoria were going to really needed to be supported in this and needed to go through these medical transitions, which would, of course, make them into lifelong patients, having to receive these drugs and having some of them receiving even surgical procedures to try to change the physical characteristics of their gender. And we became interested in this, as I said, because we saw these kids as being treated as a group. And we also understood that it was actually related to the diversity, equity, and inclusion world, because it turns out that the children who were opting for this kind of treatment were often kids who were in schools where they were treated as somehow the other, as somehow different from the other kids. They often had psychological problems. The vast majority of them have psychological problems, either depression, anxiety, even on the autistic spectrum. And they found that they wanted to belong. And it turns out that when they expressed this idea of changing their gender, they suddenly were seen as an oppressed group. And the diversity, equity, and inclusion regimen says that the whole world is divided up into oppressed people and oppressors. And who are the main oppressors? The main oppressors are white people, particularly white males. And who are the oppressed people? Well, virtually everyone else. And transgender individuals were certainly viewed as a part of the oppressed class. So these children, in a sort of paradoxical, ironic way, suddenly found themselves to be supported because they had become an oppressed person. They may have been white, and now they were no longer just white kids, but they were transgender kids, and therefore they were worthy of the status of being the oppressed. And we've worked very closely with a number of children who have gone through some of these transitions and have realized that it was a terrible mistake. Probably the most famous one of these is a young girl named Chloe Cole. Chloe is on the autistic spectrum. She speaks about this. She's a lovely young woman now, but when she was 12 years old, she started on puberty blockers because, again, she felt, and she speaks about this, she felt like she didn't really belong in school. And once she decided that maybe gender transition was something that she ought to explore, she suddenly became sort of a celebrity and was treated specially because she now was one of the oppressed people. She then was taken to a gender clinic by her parents who were concerned about her. She was immediately told, yes, you should go under on a medicalization regimen in order to change gender. And her parents were told, either you accept this, either you have a live son or a dead daughter. Those are your options. And she went on the medication. She had her breasts removed when she was 15, and now she's a 19-year-old realizing that this was a terrible mistake and that she was denied the opportunity to be a woman. She was denied the opportunity to go through puberty, which is really the problem with this whole gender affirming care model, which is that children need to go through puberty. And the ones who express some gender dysphoria, if they're allowed to go through puberty, over 85% of them then adopt whatever the gender that they were born into and live normal lives. They may be gay, they may not be gay, whatever, but they haven't been mutilated by surgical procedures, and they haven't received medications that have altered their ability, for example, to have children or to even develop normally, psychologically, normally in terms of their bone development. All of these are disrupted by puberty blockers, or at least potentially so. So our organization has taken that on, and we've been sponsoring legislation in that arena as well. We've sponsored legislation in 23 states now, the most recent of which was in Ohio, where the governor vetoed the law that was passed by both houses of the legislature, but then they overrode his veto and banned any kind of gender transition medicines or surgeries in children. Our organization takes no position about adults. Adults decide they want to change their gender and live a life as in a different gender. That's their business. The wisdom of all that will depend on the individual, but we feel that children are unable to make those kinds of judgments, and therefore they cannot give informed consent, and their parents are frightened into supporting these activities by this idea that their children will commit suicide, even though the literature shows quite clearly that children don't commit suicide in any greater frequency if they transition. And even if they do transition, many children who are going to commit suicide do commit suicide, even though their transition has occurred. And I'll just finish about this issue by pointing out that there are now 5 European countries and 3 others. The 5 European countries, Norway, Denmark, Sweden, Britain, and I think Norway, Denmark, Sweden, Britain, and Finland have all decided to markedly curtail the gender activities in their countries, even though these activities began in Europe. The first cases where children were put through these pathways was in the Netherlands. Turns out that people have tried to repeat studies to show that these treatments are beneficial to the psychological well-being of children who express gender dysphoria, and it just isn't the case. And the leading physicians in these nations, which mostly have centralized national health services, have all decided that they were doing more harm than good by putting children through gender transitions, and they've really restricted it to very, very rare cases of individuals, and often in a research protocol. So our organization works on these 2 fronts, pushes very hard against them, and hopefully, we're starting to see some effects. I think it's very unfortunate that we've had to go the route of legislation, that we've had to ban these procedures, and we've had to push back against DEI through the legislative arena. But unfortunately, the United States, with its great radical individualism, anybody who's a physician can open up a practice and decide they're going to treat patients this way, whether or not they're particularly skilled at it or whether or not it really benefits patients. So that's what's going on. There are over 100 gender clinics in the United States, and it's really been pretty much out of control until the legislatures have stepped in and said, no, the time has come to really examine this carefully. So I can talk more about the gender issues. There's lots of interesting aspects to it, and conflicts among physicians in the United States and between physicians in the United States and those in Europe. And it's quite a story.
No, that's amazing. It's a lot to unpack there. Maybe first, I'd kind of like to touch on, the name of the organization, Do No Harm, and you can tell us the derivation. Obviously, it's medical in a sense of what the physicians should be doing. I also like the way that kind of these portmanteau words come together, not quite, but social justice. There's a lot to unpack there. In a sense, social justice is the misapplication of justice. If you, shoplift and you get caught for it, and you go in front of a judge, ostensibly there should be some repercussions and ramifications from your having shoplifted. And social justice will take that away from the actual act and the actual personage and the actual crime and the actual damage, and bring it into some kind of other context, which is in a sense a Marxian construct to figure out what class you belong to, because it's always about the class struggle. And you had justification, even though the owner of the store had justification to have the stuff, to be able to sell it to somebody else and so forth. You had the opportunity to go get money, blah, 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 blah. So social justice is in a sense an inversion of justice per se, and by taking in characteristics that have nothing to do with the actual case. And I only bring it up because in a sense it's de-individualizing the application of justice for that person and for the person harmed as well. And again, brings out the concept of do no harm. And if you had a justice practitioner doing that in your case, presumably the case would be thrown out. O.J. Simpson either slit Nicole Brown Simpson's throat or didn't, and Mr. Goldman as well, I gather. And whether he was an oppressed group, I think at some point that entered into the equation unjustly in a sense, because it didn't bring Mr. Goldman back to life, nor Nicole Brown Simpson. And so you wouldn't want justice practitioners doing that. That would be a miscarriage of justice. And to have physicians doing that as well takes away, the essence of medicine. I think that's really a point that it's not social. You don't necessarily want social medicine. I'm not talking about socialized medicine, which is maybe an extension in a sense, but social medicine is, I come in with a wart on my finger, and maybe I shouldn't be treated because, for the obvious external melanin deficiencies I might share, or whatever genetic lineage and all that kind of stuff, and I might have not to have that wart. Maybe I deserve that wart or something like that, and it's emblematic. And this kind of like classification of care is misclassification. We wouldn't want to see an auto mechanic who doesn't want to treat your type of car, or you because you have that kind of car, or thinks you shouldn't drive at all, or wants to treat climate change by crashing, by trashing your car entirely. Basically, I have great respect for certain auto mechanics and less for others, but the ones I pick out are the ones who are going to, look at my car, diagnose my car, fix the right little widget or gadget in it, put the car back on the road, and leave it up to me, like how much I want to drive, whether I should be driving, all that kind of stuff. There are other statutes that have nothing, way beyond the purview of the auto mechanic. And I think doctors, in a sense, have become too full of themselves to think they're not auto mechanics. Again, I'm not trying to impute auto mechanics or physicians. I think it's really has a similar causal relationship, that you go to see somebody to fix something. And if you want to hear talk about social justice, whatever, then you'll do that someplace else. But I think it's a misapplication of the role, and it's kind of a form of abuse, in a sense, on the physician's part to think he knows so much about everything when he went to medical school, and he might have learned about kidneys, he might have learned about toenails or whatever it happens to be, and he should be go back to doing that. So that's more of a statement than a question. But the question, I guess, would be, what is do no harm? What's the essence in medicine, and how who said it originally? What are the oaths and precepts by which physicians have been operating and should be?
Yeah, well, no, that's right. I think I think the essence of the Hippocratic Oath, from whence do no harm is derived. That's the first injunction for physicians, because you have to remember when the Hippocratic Oath was developed, physicians really couldn't do much to help people other than to comfort them, and they could do a lot to hurt people, because all of the procedures that they were attempting to do generally were ones that we currently wouldn't even dream of doing. All kinds of herbs and things that weren't effective, or maybe even dangerous. Bleeding, they used to withdraw blood because they thought that was beneficial, and so on. So the idea that physicians should force themselves to be certain that they're not harming patients was really the best medicine for many, many centuries. Now we have lots of things we can do for people, but still we have to make sure that we don't hurt them. And you're very right in saying that if we adopt approaches that aren't beneficial, then in a way we are hurting patients. And one of the arguments that we've put forward, and others have as well, is that if you decide that the reason that African American communities have poor health outcomes is because physicians have been racist towards them, then the way you approach that is by trying to eliminate racism on the part of physicians. On the other hand, if the reason that African American communities, let's take the example of maternal mortality, which is much higher in Black communities, if the reason for that is because Black women don't get enough prenatal care, only 40% of Black women actually visit a physician in the first trimester of pregnancy when they're pregnant. And it's early prenatal care, which prevents severe hypertension from developing. It leads to the best nutrition. It leads to the opportunities for a child for a fetus to be carried through to term, and therefore dramatically reduces the chances of complications of pregnancy. But if you decide we're not going to go out and try to make sure that Black women get good prenatal care, instead we're going to send their OBGYN doctors to implicit bias training, then in fact you're wasting everyone's time and you're not doing anything to improve outcomes. The same way, if you're concerned about the high amputation rate amongst Black men who have diabetes, and we know that that's a fact, they have very high amputation rates, and you decide the reason they're having high amputation rates is because physicians aren't willing to do less invasive procedures on them in order to improve the status of their extremities. And so you send the physician to implicit bias training instead of figuring out how to have outreach to the Black community and get patients to come in earlier when they start to have early symptoms of poor circulation in their legs and therefore prevent amputations. You're hurting patients. And that's part of our view of all this, is that the evidence for racism on the part of physicians is meager. Certainly it happens on a rare occasion, but the idea that this is some sort of systemic factor in the poor health outcomes that occur in the Black community is just wrong. The literature is filled with terrible studies which make this conclusion without the evidence to support it. And the conclusions that they've reached and the approaches that have been taken are just...
It's generally not race per se. It's generally class. The Nigerian, influx in the last, say, 40 years or so, Nigerian Americans actually do better on average economically than whites do. And certainly they do better than the average of indigenous, long-term post-slavery American Blacks do. But it's somewhat divided. It depends whether these are kind of entrenched multi-generational inner city Blacks or not. Color per se is not the thing. The Nigerians kind of have a different ethos. They're coming from a poorer place. They want to do well. They have much more of I guess, there's generally a little bit more kind of religious practice, and they are, going for the ring. They're here with a purpose, kind of similar to, Cambodian families or whatever. They leave oppression and they see something better and they want to go get it. And for better or for worse, the inner city kind of harder core, more multi-generationally entrenched Black underclass has been that way, stays that way, and has a different ethos in a sense. And it would be lovely that everyone kind of realizes it differently, but it's hard. In the context of inner city schools, if you happen to be great at math, that's not necessarily commended or rewarded. The dad's not necessarily at home, and amongst your classmates, you're seen as a four eyes and nerd or whatever, and you're probably going to get the brunt of it. And so it's a much more successful way in the short term, as a male at least, to be part of the crowd and to be dismissive and to dislike school and whatnot. There are multiple dramas. I'm not making any of this stuff up per se. You can look at Chris Rock had a series out on this topic. He actually had a really amazing comedy piece, which whose name I can barely even quote. It's Black versus N-word, which he says in the vernacular. And he talks about Blacks being more racist than whites because they also hate the N-word. That is to say, in his context, the underclass Blacks who are continually kind of like grinding the system and so forth. And it's like, the Bill Cosby, unfortunately, had his his really horrible dark side. But the essence of the Cosby Show was, to bring out, to call out that there are bad behaviors. I think it's Alvin Toussaint, with psychiatrist, psychologist on his team, MD, and to call out some of the lesser behaviors within a community. It's not to say they're unique to the Black community. I think every community has that element, there were Jewish gangsters back in the day, and there were you pick the brand. There's Albanian gangsters, there's Cambodian gangsters, and so forth. Everybody has good and bad. The question is whether they are kind of evaluated appropriately and churned through the system. But Thomas, I'm sorry to go on like this, but Thomas Sowell, who is Black, he's an octogenarian, amazing economist slash almost social philosopher at Stanford, the Hoover Institution. He had a book which I think is hugely seminal. It's actually come from an essay. I think it's called "White Liberals, Black Rednecks," and it's basically the way that white liberals have enshrined and almost deified the kind of worst characteristics within the Black community, kind of coming from the redneck part of the South up north, and it's part of like what we see today in gangster culture and whatnot. And it's kind of a reverse of what should be the better behaviors within a community, rewarded and so forth. And to accept less and to assume that people do less because of their color, I think is not helpful to anybody in particular. That's more of a diatribe than a question. But in the context of that, what are the things that physicians can or should do, when they're seeing patients of any particular race or what?
Yeah, I think the issue is to treat them as individuals, as you say. If the reason that they have a bad health problem is because they've come in late in the course of their illness, that's one thing. On the other hand, to ignore racial characteristics is also a mistake, because let's take one little example. And now you have to understand what race really, the argument has been that race is a social construct, that we treat all Black people the same, when obviously, as you mentioned, Nigerians are different than Ghanaians, or different from Caribbeans, and so on. But the issue is, what's wrong with that individual patient? And one of the things we do know is that individuals whose origins are in West Africa, and all these characteristics are really about their geographic origins, individuals whose origins are in West Africa, who were enslaved, brought to the United States, and their ancestors are here and make up a large fraction of African Americans. Their progeny are here and make up a large fraction of African Americans. These individuals have an increased risk of a gene. The gene mutation is present in people in West Africa because it protects against African sleeping sickness. And over many centuries, this gene has become more dominant in the community because it's protective. It's a useful gene. Except it turns out this gene, which is now present in something like 25 to 40% of African Americans in the United States, is a gene which increases the risk of kidney disease. It's not about their skin color. It's not about being Black. It's not any sort of a genetic deficiency. It's just the reality of a gene which is transmitted along because of this geographic origin of the community in West Africa. That gene, which had a benefit there, has a detriment here in the United States, has a detriment in Western societies. And it's the reason that African Americans make up about 30% of the dialysis kidney failure population in the United States, even though they're only about 10% of the population. So again, you have to treat reality here. If a patient has a problem because they have poor health literacy and have come in late in the course of their disease, that's one problem. If the problem is they have a genetic abnormality that's going to put them at increased risk of a problem, you have to face that and say, yes, there is a genetic abnormality here. Sickle cell anemia, of course, is well known to be something that is present in communities around the Mediterranean area. It does reduce the severity of malaria, which is its benefit. Its harm is that it produces an illness. If you get a double dose of that gene mutation, that really produces terrible kinds of illness. It doesn't diminish African American individuals. It doesn't promote them in any way. It just is. It's a biologic reality that has to be dealt with. And I think what we're really talking about here is talk about treat reality. If the problem is his behavior has been such that they've led to increased risk of illness because they've avoided medical care when they really should have been seeking it out, or because they've engaged in behaviors like smoking and eating too much and becoming obese, or not exercising or other lifestyle things, that's the problem. The problem isn't that someone's treating them in a racially offensive manner. The problem is behavioral. And it's just a question of dealing with the reality and trying to discover what the reality is. So our organization, that's what we're devoted for. We're devoted for facing reality here, speaking honestly about racial issues, speaking honestly about sources of illness, speaking honestly about the validity of gender affirming care, just trying to identify what the literature and the science really says about these things, and not accepting opinion, and not accepting bias, and not just accepting groupthink about how there are oppressed people and oppressors and all this. These are all theoretical concepts that have been created. They don't represent reality any more than any other idea that might represent reality. They need to be tested in their own right, and they need to be shown to either be correct or not. And for the most part, they're not correct. It's not the way humans interact. It's not the way that people are currently being treated. And yet that's what's being promoted. And let me point out a couple of the obvious dangers that have occurred because of this so-called DEI approach, the so-called diversity, equity, and inclusion approach. The first has been the obvious eruption of anti-Semitism, which has occurred in the United States and occurred around the world because Jews are being viewed as a monolithic group of people with certain characteristics that are to be denigrated by others. And this is what anti-Semitism is. It's taking individuals and putting them in a group, saying, well, they're Jews, and giving them characteristics that are claimed to be characteristic of the Jewish people, and then saying that all individuals within that group have the same characteristics and are worthy of being, treated poorly and being denounced because of these characteristics, when obviously it's absurd. People need to be treated as individuals. Another really tangible example of where DEI can go wrong is this idea that Black patients need Black doctors, that we have to treat them differently as a group, not only the way they're treated by all physicians, but specifically, they're not going to have good outcomes unless they have Black doctors. Our organization has been doing a fair amount of research in this area, and we've recently written a report that's been authored by Jay Green and Ian Kingsbury, two very accomplished social scientists. And they reviewed all the literature on this. And let me give you one example. One of the things that said is that Black patients are not going to communicate well with white doctors. There actually are over 40 studies of this issue where patients are queried after they've had interactions with their physician, and to see whether when Black patients have white physicians or Black physicians, whether they communicate better with these two groups of people. It turns out of the over 40 studies, there are 6 studies which show that Black patients communicate better with Black doctors. There are 8 studies which show that Black patients communicate better with white doctors. And then there are all the other studies in between of the somewhat 40 studies, which have failed to show any difference between communications between white and Black, white doctors and Black patients, or Black patients and Black doctors. So the conclusion from this is just train the best doctors. Don't go out and decide you're going to create a cohort of Black doctors simply because that's what's going to lead to better health outcomes for Black patients, because it won't. Now, if you want to choose Black doctors who are equally qualified as any other individual to be a physician, fine. But if you're going to take Black individuals and allow them to get into medical school because they're Black, even though they're less qualified in terms of their academic achievements up until that point, then you're not doing Black patients a service, because Black patients, just like any other patients, want the best doctors. They don't want people based on race, for the most part. And therefore, there are 2 examples of how the diversity world has gone awry, and identity politics have led to what Yascha Mounk, who's a social scientist at Johns Hopkins, has called the identity trap, where once you start dealing with people as simply as members of groups through identity politics, all that ends up happening is division, strife, conflict, and it's not the path towards individuals living in a harmonious society.
Well said. Now I'm thinking back to my auto mechanics, whether, I have a plumber of one race and an electrician of another. It's like, should I only, seek out, electricians who look like me. I don't want that per se. First of all, it'd be hard to find. But you've probably heard of this thing coming up next week called the Super Bowl, and which I just realized somebody put a picture of an owl, and if you put the B on the other side, it becomes a superb owl, which I never thought of. I'm kind of a word guy, puzzles and whatnot. So it's either superb owl or the Super Bowl is coming up, and people have an interest in this kind of thing. Why? Because it's frankly a craven meritocracy. It's basically pits the best, against the best, and obviously not every single person on that team, 53-man roster, is the best at his position, but cumulatively they are. They beat all the other teams, and there they are in the Super Bowl. And people want to see that because, and mind you, it would be a horrible, horrible, horrible event if for some reason the referee decided that there was a penalty or not because of the race of one of the two players. If a white player, pushed a black player, that would be a penalty, and vice versa would not be a penalty, or whatever the referee would be kicked out. There'd be uproar, pandemonium, blah, blah, blah. Las Vegas would go nuts, etc. The whole thing is predicated upon an absence of discrimination on the field. That's the whole purpose of the referee. He's got black and white stripes, by the way. And in the NFL, for instance, there are, I think, a grand total of 0 white cornerbacks. That's the position that guards the fastest guy in the field, Tyreek Hill, one of the wide receivers. And for some reason, there are 0 of them. And I think there are approximately 0 in the college ranks as well. And so people have written on this topic, whether it's a genetic kind of trait that certain kind of the speed and acumen to track somebody else's movement, why blacks do slightly better at that, or whatever, what it is, or whether it's become kind of a fraternity in the sense that a white guy can't crack. I have no idea. I don't know the answer to that, but nobody's thinking about that.
There is a sprinter's gene, so there is a gene for fast twitch muscle, so that sprinters tend to have. It's not uniquely to black individuals, but it is a gene that if you have that gene, like Christian McCaffrey, the great back for the 49ers, his grandfather was Dave Syme, who was an Olympic sprinter.
Wow.
So, this.
I didn't know that.
Yeah.
But it's a funny thing, but there's no uproar in this country about black cornerbacks. Now, if all the cornerbacks at one point, as were, vast match of the quarterbacks, white, then it isn't an issue. When Donovan McNabb came up and Steve McNair and, others, Johnson was named Doug Johnson, whatever, they were, first black quarterback in the Super Bowl, that kind of thing, becomes an issue. But nobody's talking about, the first white cornerback in the Super Bowl. It's always a kind of a unilateral thing. And nobody's really fussing and messing over the fact that, vast amount of the NBA, the NFL are, black, and fine, because it's a meritocracy. And I think whatever actually bubbles up, that's the thing you want to see. You don't want to see, a Cambodian team versus an Armenian team, and so forth, per se, unless maybe you're watching the World Cup. That's another story. But in the context, but even then, it would be like, which one is better? And in the context of sports, we kind of pull the, we take this away. We want the best skater in the NHL. We want the best jumper, playing on your basketball team, and whatever that happens to be, whether it's Slovenian or Fastvenian. Anyway, so that's kind of a side point. But I think that points to the fact that what we really want in our own personal time when we watch the Super Bowl, we don't want to watch a team of this certain team that looks like us. We don't want to watch a team of older. We want to watch the best, and when we want eye surgery, we want the best. I recently had heart procedure. I want the best. That's that. And presumably this again, the social contract is that person is there to do the best. He wants to be the best. He's going to be graded for it. And we have some different grading curve. That doesn't really help anybody. And fortunately, Ibram Kendi, sort of self-immolated for money, as did a fair amount of the BLM cohort leaders. And so it shows they have the same interests as everybody else. They want power and money, and a lot of times they abuse it. But this kind of like dictum that racism is going to cure racism, is a little bit like there's a Theodorus of somebody. Say Steve Martin had a Saturday Night Live skit probably 30 years ago, where he's doing leeches. He's an old-time surgeon, barber, whatever, and he puts leeches on people when they're not doing well. The answer is what? More leeches. And I think that we've kind of doubled down on a lot of what we have seen as bad practice, and we're only going to get more of it.
Well, let me just say, I think, one of the rejoinders to all this is, well, they don't have the opportunity. Black quarterbacks blacks did not become quarterbacks until they were given the opportunity to be quarterbacks, and then they turned out to be excellent quarterbacks. And so there is a certain logic to that. But on the other hand, when it comes to something like medicine or engineering, you have to have the capacity to do these things. And it's important to try to identify people that have the capacity to take on difficult things like neurosurgery, like cardiac surgery, like engineering, like things like that, and not to put in people who are unqualified simply for the sake of diversity. So I think it's very important that we make sure that the educational systems are such that kids who have the intellectual capacity to take on these difficult intellectual fields are able to have that opportunity. But if they don't have the capacity, then it's not the job of society to say, well, we're going to give you that opportunity anyway, even if you don't have the capacity to fulfill that role. And you're sort of saying the same thing about the characteristics of athletes. You have to have the capacity to do that job, and then you should have the opportunity to do the job, but you shouldn't have the opportunity without the capacity. And that's unfortunately what's being foisted on the public in the name of fairness, in the name of equity, in the name of an equal outcome for all individuals. And it's not fair to the public, and it's not fair to society to try to superimpose this so-called fairness on the individuals. We have to treat people equally. We have to give them equal opportunity, but opportunity starts in childhood. It doesn't start when they finish college, for example. And say
that is very, very true. And it's a tragic thing when a child is not kind of nurtured to his full capability. But such always has been life. It's a rare situation that we get to kind of choose what we want to do. And we have leisure, and so life was. I think it was Hobbes. Life is what is it? Difficult, brutal,
and short.
Short. I mean, historically, if you look at the number of leisure hours we have now versus say in 1880, I just saw this little meme, or somebody compiled the stats on a meme, but a spreadsheet. I think we have something like 5 times the amount of leisure time that people had 150 years ago. What do we do with it? Is a good question. We have lots of choices and so forth. And a fair amount of people's health comes down to, the ramifications of how they've made their choices. And people make choices differently. And I think we sort of have to respect that to some extent. We can't make everyone take their cholesterol pills. We can't make everyone not smoke. We can't make everyone not drink. There are certain pleasures that people have from certain activities, including, basically saying F you to everybody else who's in charge. So people can live their lives, differently. They can live them brightly or not. Anyway, we're kind of rounding out the hour here. It kind of went by fast. But I'm curious, I'd like to put up your webpage so people can see it and maybe talk about some of the themes. I guess, one thing that I would like to hear you talk about, partly because you have a University of Pennsylvania accreditation or history, is Liz McGill in front of Congress. But moreover, kind of the bleeding over of some of the decidua of the results of that encounter from Claudine Gay's plagiary, and basically her position in a role for which she was not qualified. I think she's somewhat emblematic of that situation. One of my good friends actually worked with her 1,000 years ago, before she was an academic mostly, in kind of a consulting firm. And they all had a very, very intense kind of boot camp to be this kind of, Deloitte level consultant. And she didn't finish it. She wound up meeting her husband there and left for, greener pastures, I assume. But the fact that she was kind of upwardly mobile, despite not necessarily having the chops intellectually to do so. And it turns out her work was cribbed. And mind you, she didn't even crib like, Galileo or anything like that. She cribbed somewhat lesser lights of retread, DEI material, which, in and of itself was not, gleaming and whatnot. how much of this is playing out in the medical world, of people kind of being passed along, A, and B, how much when you mentioned those studies of saying X and then anti-X and this all this kind of stuff, how much of our studies are actually valid, given that what we're seeing more and more of the porosity of the data and the flimsiness, kind of sandcastles of medical information.
Yeah, it was. So, one of the concerns that I've had is that more and more, in the name of diversity, the academic achievements of individuals have been sort of put as a lesser important issue than the so-called holistic story, which meant, have they overcome problems in their lives? Have they dealt with struggles that they've had? Have they been victims of racism? Of course, racism becomes anytime anybody ever, criticizes you for anything, they're doing it on the racist basis, as opposed to you just maybe didn't perform so well. And so therefore, medical schools have decided more and more to forego some of the usual qualifications. For example, the MCAT exam. The MCAT exam was put in back in the 1930s in order to make sure that students who got into medical school could actually finish, because the attrition rate in those days was very high. It was like 30%, maybe even higher in some schools. So an exam was put in to show that the individuals who got into medical school actually could do the science. Well, this was very successful for many, many years. But now a number of schools, for example, Penn has a program with to take in 10 students every year from historically Black colleges and universities who do not have to take the MCAT exam. All they have to do is maintain a 3.2 average. They have to have had a fairly successful SAT or ACT score, not the top of the line, but a successful one. But they don't have to take the MCATs, and they don't have to produce college activities more than a 3.2, I think was the average score. Well, that means that they're going to take 10 kids in a year at Penn at least, who we really don't know their intellectual capacity to do the work. In order to sustain these 10 kids, 10 children, 10 young people for 4 years, they're going to have to make passing the curriculum a little bit easier than it used to be, because they don't want them falling out. And in fact, it is easier than it used to be. And in fact, over 98% of, I think over 97% of students who enter medical school get to graduate if they want to graduate. There's very little attrition. Other schools, like in law and nursing and in veterinary school, the attrition rates are over 10 to 15%. It used to be 10% in medical education as well. Now it's less than 3%. So what's the evidence that they're not doing well once they go further on? Well, we do know that how you do on exams tends to be a predictor of how you do in training. And we do know that now in training, there have been 2 large studies that have showed that minority students in medical residency programs perform less well than their white and Asian peers. Now, this was shown in a study that was about 2 years ago from internal medicine training programs at Harvard, Virginia, and at Emory, where the assessors decided that the minority students, as a group, performed less well in terms of their professionalism, medical knowledge, preparation for practice. That's not to say there weren't some brilliant kids amongst the minorities that were better than anyone else, but as a group, they perform less well. And most recently, a very similar study came out of individuals in emergency medicine residencies. And the same thing was found, that the Black kids, particularly the Black women in these programs, perform much less well. In each case, in each study, the authors of the studies concluded that the problem here was that the assessors were being racist. They didn't even raise the possibility that these poor performances were real and didn't reflect reality. I was actually chastised by Penn Medical School and by some of the senior people there in public, because I tweeted out about the first study that I mentioned and said, maybe they just didn't perform very well. That was felt to be a racist statement, but it's not racist. It's reality. Reality is that if you're taking people in with lesser qualifications, some of these people are going to perform less well as they go through their careers. And in fact, that's what we're starting to see. So we are putting the public at some risk here. We are creating cohorts of physicians that are not of the highest potential. That's not to say we haven't had physicians in the past that weren't of the highest potential. Of course, that happens, but it ought not to be something that's intentional. It ought to be something that's
And
an
it shouldn't be,
unfortunate,
it should be encouraged per se.
and it shouldn't be encouraged. Yes.
Yeah, no. So on a total kind of quasi-personal, but yet internationally public health concern, my topic the last few years has been Zika, microcephaly. Moreover, its complete disappearance as a phenomenon. And what you're saying there resonated for me. I always bring it up at the end of the show anyway, just to kind of hawk my book. But the funny thing is, aside from the fact that the phenomenon was cultivated in order to deal with supposed inequities between the poor north of Brazil, hotter, poorer, darker skin north of Brazil, and they kind of have a grudge or envy towards the south of Brazil, richer, more European world, business and kind of culture, government, blah, 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 Brasilia, Rio, Sao Paulo axis. There's a bunch of inherent Brazilian stuff. And so a group of physicians posited that they were going to find a new virus there. And they were hoping for chikungunya virus to show up in Northeast Brazil so they could deal with the inequities of the system and bring money and attention, and it would flow to Northeast Brazil. And lo and behold, somebody kind of bait and switched and found Zika, which was a dengue virus, harmless to humans heretofore, and presumed that was there. And then somebody else attached it to this microcephaly without any background record of whether there was any more microcephaly than usual. And then we're off to the races. It became a panic, pandemic, whatever you want to call it, PHEIC, by terms. And but the point of my mentioning it is that these 8 years later, basically 2024 now, there's been no microcephaly increase anywhere on Earth as a result of Zika or for any other reason in the interim, including in Northeast Brazil, where supposedly it happened the most. And for some reason, it didn't happen in Colombia, although the mosquitoes don't, discern borders, whatever. So it happened in one place and not another with the same mosquito, the same virus, blah, blah, blah. At hugely, orders of magnitude, like 2 orders of magnitude different rates. Anyway, so even now, years later, nobody will come up with the fact that maybe A doesn't cause B, except for me. And it's like a funny thing, that the reality of a situation is the reality of a situation. You can keep, claiming one thing or another, but it becomes a case kind of the emperor's new clothes. And at some point, the kid points to this thing out, and then everyone realizes wearing no clothes and all that kind of stuff. And I think things move on. Or people just find different emperors. They find different places. If medicine continually, has this unequal standard for what they want the result to be, and they posit that in advance of the studies, and the study's only there to confirm it. And if the facts don't follow basically the quasi-fiction, then the facts will fall away. People will not follow that forever. They follow it to a point, and then they're done. If your football coach only wants to have, he's an Armenian guy and he only wants to have Armenians play, at a certain point, people will stop watching that team. Unless he's incredibly right about some theory that we're missing. And it's like, so at some point, what Herb Stein, the father of Ben Stein, said, that which cannot continue doesn't. And so here's the question for you. I think Tucker Carlson was bringing this up the other day about primary care medicine. Are we at an end? Will we lose the people? I mean, because I think, the model of a patient go seeing a doctor, that's a nice thing. I'm a primary care doctor by training and by history. But people have other tools potentially that can kind of crowdsource things. You can put a picture up on the internet. Is this a wart? What should I do? Can I go get some wart juice? They don't have to see a doctor for everything. They can probably get their earwax out on their own. Certain things people may move away from doctors to find other models. Is medicine, if we keep kind of making the foundation into cotton candy, is it going to last?
I think that trust in physicians is less than it used to be. The pandemic was a disaster for science and for public health because there was so much misinformation that was promulgated on all sides, including by the experts. Dr. Fauci said things that he knew weren't true, and yet he said them. For example, he first said that masks were of no use, and then he said masks were absolutely required. he was doing it because he thought there weren't going to be enough masks for healthcare workers. But you have to be honest with people, and you have to tell them the truth, and you have to be right. I mean, if physicians are pushing these racial ideas, and patients see this, they're going to be very concerned. And now we have Jewish individuals who have seen physicians, often physicians who have emigrated from the Middle East, going on various social media and proclaiming that Palestine should be free from the river to the sea, and knowing that this meant that they were going to eliminate all the Jews from Israel. A Jewish patient who sees this comes to the hospital, says, is this patient, am I going to be treated fairly? Am I going to be treated properly? The same for Black patients. If Black patients continually told that their physicians are racist, the way some of these race hustlers keep saying, they're not going to trust their physicians. They're not going to come to the hospital. They're going to avoid medical care. It's going to be to their harm. So it's very important that we stop this kind of racialization, that we stop this idea of treating people as members of groups and start treating them as individuals, and don't tell people that we have attitudes based on group characteristics, because that's so dangerous. So I think we will undermine the trust that physicians have in patients, and patients will start seeking alternative ways of getting health care, which is not in their interest. I think one example of this is the idea that Black women are at great risk of delivering their babies in white hospitals. So therefore, they should start delivering their babies at home. This is a catastrophic sort of thing that's going to lead to terrible outcomes, because the reason that we moved from home deliveries to hospital deliveries was to really guarantee the health of the mothers. And if some woman has a terrible postpartum hemorrhage at home with somebody who's not really trained how to handle this properly and doesn't have the facilities available, women are going to die over this new initiative. And I understand that it socially sounds better and it sounds nice in your home and all this sort of thing, but the rare complication that occurs is going to lead to a terrible outcome. And this is all because of this undermining of trust based on identity politics. It's quite terrible.
I'm with you on that. So I want to show people your X page and also your web page, so they can help find and support you. Taking me a second.
Yeah, we have, as I said, over 7,000 members, and we love it. So it's donoharmmedicine.org, one word.
Yeah, and I have it here.
Yeah. The other thing that they can look at is my book, which is Take 2 Aspirins and Call Me by My Pronouns. And I think they'll find a lot of the things we talked about are in there. The book is been published within the past year, so it's still something that's worth, I think, their consideration. It's on Amazon, and
Okay, let's see. I can't pull it up right this second, but I'll get that up momentarily.
Okay.
So people can find you there, and on Amazon. What is it? Yeah. Take 2 pronouns.
Take 2 aspirins and call me by my pronouns.
Oh, I'm sorry. There we go. I got it backwards. So I'll see if I can pull up the book here. Here we go. So here's the book. I apologize. Right. So it's Take 2 Aspirin and Call Me by My Pronouns. Why turning doctors into social justice warriors is destroying American medicine. Stanley Goldfarb, MD, and they can find it on Amazon, probably elsewhere. And I like the cover art. Interesting. And so that's there, as a word of self-promotion. The people, if want to help support my video cast here, they can go to Amazon similarly and find Overturning Zika, the Pandemic That Never Was.
Interesting.
Addition, no additional price. They get a picture of me on the cover right here. And it's been an interesting ride because, medicine is a funny thing. It's just I sent out letter to maybe I don't know, 1,000 different people who had touched on the topic of Zika through their research. So I pulled emails and whatnot. I sent shorter versions of my book to them, and just wanted to hear comments. I basically got total silence. There's not really any interest in hearing counter views if you're getting kind of funded in a certain way. So that there we have it. Just as a total sidelight, I actually did write an article for Brownstone on Dr. Fauci, and you were mentioning some of aspects there. This is the article, Dr. Fauci's own gain of function, and how he basically, despite his prevarications and wobbliness and pivoting against tried and true medical dicta, managed to have his own gain of function. His functions accrued over time. He got more important, despite basically whatever the nice word for lying is, molding the truth to fit circumstances. In 2004 or 5, whatever flu was going around then, he was asked on regular talk show, but it's on C-SPAN now, by a listener, should she get the flu shot if she's just already had that flu? And he's like, I'll do my Fauci. He's like, no, there's absolutely no reason you should do that. You've had full immunity. There's absolutely no reason after the fact you'd want to get the vaccine for that problem. Anyway, he says something of that sort, and that's actually true. And then to go against that and kind of give this continual boosters for COVID-19, SARS-CoV-2 that is long gone and will never come back, is an absurdity. And whether you kind of mix it with the bivalent or not, and just kind of harken back to the old times of good old-fashioned corruption. For today's broadcast, I'm going to kind of put it up to the screen. I kind of put a timely tie on today. This is a Pfizer tie I got when they were giving out Viagra samples and whatnot, and they had these other little Viagra paraphernalia, and I got a tie and a race car, a little tiny Matchbox race car, and I have both of them. And I wore the tie today because I was kind of like, oh, well, back in the old days when it was just drug detail people that might tell you to use more Viagra or not. There's always kind of the lurk of people trying to sway physicians' minds. And this tie, I wrote my share of Viagra. I thought it was a great medicine until the other ones came out, which are equally good or maybe a little better. Cialis and Levitra and whatnot. But the tie didn't really change the way I was going to write the stuff. I wrote Viagra because it actually worked for men's ED, and if it hadn't, I would keep the tie and I wouldn't have written it. But now physicians are kind of throwing the baby out with the bathwater by abandoning their own ability to see through the little perks and gifts, and just to do what is politically expedient at any given moment. Gender affirming care, like social justice, gender affirmation is an oxymoron. And if you wanted to affirm your gender, pretty much I do it every time I wake up and hit the bathroom. It's not that hard to affirm what gender you are. Really what they're doing is a gender disaffirmation, or whatever the opposite is, and kind of having these social easy Orwellian terms does not help medicine, and medicine has to hold itself up to a scientific standard and do its best by people. And I certainly applaud your ability to be a clarion beacon, whatever the other analogy you might want in this fight. So thank you so much for being on my show. I'm going to give you cede the floor to you for last words.
Well, thanks very much. I appreciate this conversation and a chance to sort of expand on some of these issues more. And I hope people will come to our website. I think they'll find a lot of very useful information there. And we want people to join us. There's no cost to joining us. And I'm a volunteer. I get no compensation for my efforts with Do No Harm. And because I think it's really important that
well, you really should learn more from Miss Patrice Coulors from BLM.
Yeah. Well, no, thanks.
Around, take the money and run. You
Yes.
might find yourself with a home in Malibu. Well, thank you so much, Stanley. I appreciate your time.
Very much. Great talking.